Problem.
Well, thank you so much for joining us. I think this will be a good time to get started. Again, I want to thank each of you for joining today. This speaker series is focused squarely on understanding the politics and policy of COVID-19. So we're very fortunate to have two speakers join us today. This is hosted by the Department of Political Science at UMBC. And we have had great support from the Center for Social Science Scholarship at UMBC as well. So thank them for joining. Well, I want to start off by thanking you, Ms. Ciborowski, for joining us. Alison Ciborowski was unanimously chosen by Leading Age Maryland Board of Directors as the new president and CEO beginning in April 2020. Following the retirement of their founding president and CEO. She's been active within the association for more than 7 years, having previously served as in a role with a nonprofit member organization. In 2018, she joined Leading Age Maryland as Director of Member Relations, where she successfully led the expansion and development of many educational leadership, development, and peer networking initiatives. With more than 10 years of experience in aging services in a variety of nonprofit settings, hospice settings, assisted living, skilled nursing, and Alzheimer's and dementia-specific care settings, she brings to this role. Certainly passionate about the work that she does, and we're very glad to have her, as well as Attorney Erin Greenfield, who serves as a government relations consultant to Leading Age Maryland. So without further ado, thank you guys for joining us and for telling us, your perspective around the politics and policy of COVID-19.
Thanks so much for that great introduction, Eric. And I have some slides, so I'm going to go ahead and share my screen. So let me do that first, and then we will get started. Great. So like Eric just introduced, my name is Alison Ciborowski. I'm with Leading Age Maryland. And so I'm glad to be here with you today to talk a bit about how COVID-19 has affected aging services across the country, and more specifically, talk about some things here in Maryland. Before I really dig into the meat of what I am going to speak about today, our state lobbyist, Erin Greenfield, was able to join for the first 20 minutes. And so I'm going to go ahead and hand things over to him first. I asked Erin if he would share a bit about how our association has interacted with the state government here in Maryland since February. So Erin, thanks for being here. Would love to hear just a few thoughts from you since we have limited time with you today.
Yes, thank you. Can everyone hear me okay?
Yeah, you sound great.
Great, thanks. Well, thanks for having me, Professor and Alison. I appreciate it. I'm sorry I can't stay for longer than a little bit of time. I got another commitment coming up. But, COVID has, it's not a surprise, COVID has changed lives in so many ways. It's changed, interestingly enough, how you have to practice in the area I do, and in part, one of the things that you're going to see, I think, in Alison's slides are how regulated the industry is, and adding on the layer of COVID certainly complicates things that much more. Traditionally, what we would do is we would be in a non-COVID world, we would be working with departments on regulation, working with the General Assembly on legislation, and making sure that you are letting both sides know exactly what's happening and how it impacts your industry. COVID has sort of forced us, in many ways, in a good way, I think, in being way more engaged on both sides and leveraging, this is an important part, I think, of what we do, is leveraging the General Assembly, the legislature, to assist us with some of the agency interactions. So if a decision from the Maryland Department of Health, by way of example, doesn't sit well with us, we will meet with legislators who have some sway to kind of reinforce our points, and they become, in many ways, not just third-party validators for us, but very important validators when they interact with the department on some of these points. So, in many ways, what we do in both a non-COVID world, but even more so in a COVID world, is making sure that you are engaging not just the executive branch, which you have to do, but just as importantly, the legislative branch, which, as you know, is co-equal and plays an incredibly important role. I would say before COVID, my work for Leading Age was mostly on the legislative front. There was less in terms of the day-to-day interaction with the departments. That clearly has to change and has changed, given the plethora of different orders and moving parts in this industry and how COVID has touched it. So I'll be quiet as I sort of rambled on a little bit, but happy to try and answer any questions, or if there's anything specific that I might be missing, Allison, certainly point it out.
No, thanks for sharing that, Aaron. I think it's helpful. I just thought it might be nice for folks to hear about how we interact with the different branches of government here in Maryland, and I'll certainly touch on more of that as we go on. And if folks have specific questions, I've included my email address, and I can also connect you with Aaron if there are things that you'd like to hear about from his perspective. And before we go any further, I just have to apologize in advance that another fun reality of COVID-19 is working from home with children. So I apologize in advance if I do get interrupted, but I know many of you on the line probably understand that situation. So I'm going to go ahead and get started. So Leading Age Maryland. So who are we? And I have to give a shout out to Dr. Nancy Kazmal, who I see is on the line. Nancy and I are longtime friends and colleagues, so she may be the only one on the line who is really familiar with what we do. But Leading Age Maryland is an association of not-for-profit aging services providers. So what does that mean? A lot of times when we think about working with older adults, we might think nursing homes, but it's much more than that. The biggest bulk of who we represent is actually affordable senior housing. We have about 85 affordable senior housing communities that are members of ours in Maryland. And then the other big piece of our membership is life plan communities, or what you might have heard referred to in the past as CCRCs, or continuing care communities. And these are campuses with many different levels of care in one place. So they have independent living, assisted living, and skilled nursing. And then we also have hospice and different home and community-based groups that are part of our association. And we do several different things. So we provide a lot of information and updates on both federal and state regulatory changes, trends in the field, best practices. We are part of a national association called Leading Age. And so we have kind of our finger on the pulse of what's happening at a federal level and access to up-to-date information, which is incredibly helpful for our members. We do a lot of education, conferences, continuing ed, seminars. Over the past 9 months, that's been completely virtual, but a lot of our work is focused on education, leadership development, and those kinds of things. And then connection is another big piece of what we do. So bringing our members together with the larger community, with each other, to address issues in the field and work on things in partnership. And then, like you heard Aaron talk about, advocacy. So in the past, a lot of our advocacy work has focused only during the legislative session, unless there was huge regulatory changes or anything that was underway other places within the state government. But of course, over the last 9 months, that's all gone out the window. And we are, I'd say advocacy is probably at the top of the list right now for what we spend our time doing. So over the next few minutes, I'm going to share with you a bit more about how COVID has affected our field across the country and then in Maryland. And then I'm going to break down for you all just one area of the COVID-19 response, and that's testing, how it's been handled here in Maryland, and what else is still needed. So when we're looking federally, this is likely not a surprise to anyone on the line today. If you've paid attention to the news at all, you know that COVID affects older adults much more severely than it does younger populations. So 80% of all COVID-19 deaths are among people 65 and older. So the death rate is about 90 times higher than for those who are between 18 to 19 years of age, just to compare. I'm not going to read all of these statistics to you. You can read the slides, and I'm happy to provide these afterwards if folks would like to reference them. I think some of the important things to look at are the high rate of cases in nursing homes, which again, if you paid attention to the news, I'm sure you've seen that. It just makes sense that that's where we're going to see the most cases, given that we know that frail older adults with medically complex situations are most likely to fall victim to this virus, and that is who lives in nursing homes. For the most part, it's older adults with many different medical conditions, and so it just makes sense that that is where we would be seeing, unfortunately, a lot of these cases and a lot of deaths. So about 80% of nursing homes have had at least one COVID-19 case, according to some recent research. And then we know that nursing homes with higher numbers of Black or Hispanic residents have been disproportionately affected by COVID-19. And you can read more about this from the Kaiser Family Foundation in a publication that they shared recently. But there's some really interesting data. We don't know exactly why all of this is affecting these populations more, but we do have some good beginning data on the fact that it is happening, and so there'll be more to come on that as we learn more. And then another really important thing to think about, of course, there's the immediate effects of this virus, but there's also a lot of effects related to social isolation that are going to have long-term effects. And again, I'll give a shout out to Nancy Kismal on the line. I know she's done a lot of work on this as a social worker. But there are huge increases in rates of depression and anxiety in both older adults during this time, as they're seeing social isolation, especially folks in nursing homes and assisted livings. But there's also increases in rates of depression and anxiety in healthcare workers, which I don't think any of us would find surprising. And so that's something that's really important for us to be thinking about. How we can address not only the physical health challenges related to COVID, but the ongoing mental health challenges that we see. So next, I'm going to get a bit more into Maryland. And I pulled this on Friday, so it has changed since then. The data is updated every day at 10 a.m. So this is a bit outdated, even at 3 days after when I pulled it. But looking at the numbers, in Maryland, those 60 and older account for 20% of the total cases, yet they account for 86% of the total deaths. So there's just a huge discrepancy in how this virus affects us. And older Marylanders are much more at risk for suffering from this virus and having experiencing death related to the virus. So just to kind of paint a picture there of how serious this virus is. So in nursing homes, and again, this is from Friday, but there had been a total of 19,423 cases and 2,284 deaths. And again, this continues to increase. And it's important to note that the number one indicator of increased cases in nursing homes and these congregate settings where lots of older adults are living together is increased cases in the greater community. So what are we seeing right now? We're seeing huge surge in cases in the greater community, in younger individuals, so it just follows that we're going to see more cases and unfortunately more deaths in nursing homes. So Erin touched a bit about how highly regulated these settings are. So I thought I would just list out for you all who regulates and licenses these settings. So nursing homes are regulated federally if they are Medicaid, and then they are licensed and surveyed by the State Office of Healthcare Quality, which is within the Maryland Department of Health. So nursing homes have to follow both federal mandates and state mandates. And the two do not always align. Often there are differences and it can get quite confusing. Assisted livings are licensed and regulated by the state. Life plan communities, like I mentioned earlier, that have different levels of care on one campus, are licensed by the state, by the Department of Aging, which is separate from the Department of Health. Then they have the Office of Healthcare Quality involved for higher levels of care, so for assisted living and nursing homes. And then if they have a skilled nursing that works with Medicare or Medicaid, they're also federally regulated. And then affordable senior housing, like I mentioned, is regulated and overseen by HUD and also state and local health departments. There's a lot of different cooks in the kitchen. It was a confusing regulatory environment before COVID. And so now that we are in this pandemic that's affecting older adults, it has gotten even more complex. So what are some of the top challenges? This is by no means an exhaustive list, but some of the things that have really been most difficult for aging services providers during this time are the rate of change. So I'm going to illustrate for you in a moment all of the changes that we've seen just with testing in the state. But since March, operations have really changed within nursing homes. Visitation was restricted, there's screening processes in place. Folks had to shut down entrances and have one central point where everyone was entering the campus. We've had to learn how to cohort individuals who have been exposed or who have tested positive. We're cohorting staff, so they're only working in certain areas. Folks are using personal protective equipment, which I'm sure you've heard about as well, and use different types of personal protective equipment based on if someone is exposed or positive. And so there's just a lot of changing variables that change week to week as we learn more about this virus and sometimes day to day. Another challenge is just the scarcity of resources. So there have been challenges since the beginning of the year with procuring PPE, so gowns, gloves, face masks. There's just kind of these rolling shortages of different supplies that it's just everyone is using these things, hospitals, and this is a global pandemic. And so the supply chains have really just been strained and not able to keep up. Then a third challenge is really these unfunded mandates. So the state and the federal government have continued to kind of change the rules to help try to keep people safe based on what we know and what we're learning about the virus. But a lot of these changes have not been funded and they have caused increased costs and also huge losses in revenue. So one example of that folks might not think about is that a lot of how nursing homes make their money is through doing short-term rehab for people who have had hip replacements, knee replacements, different procedures that require them to stay in a nursing home and get physical therapy, occupational therapy, all of those things. But at the beginning of this pandemic, a lot of folks started opting out and not having those procedures. There were restrictions placed on folks getting those elective procedures. And so that stream of revenue for nursing homes has really dried up. So at a time where they're seeing huge increases in costs, they're also seeing these huge revenue losses. And that's our next point. So providers are paying for more PPE, testing, staffing. Some of our members have reported since March millions of dollars in losses in revenue. And in a recent survey that LeadingAge completed, 72% of those who responded, the nursing homes that responded, reported they will be unable to maintain operations for another year at this rate. 40% said they would last less than 6 months. And I know from speaking with our members in the state that we have some members that are already thinking about delicensing some of their skilled nursing beds or cutting back on the number of services that they offer because they simply cannot sustain it. Another challenge is really the conflicting guidance and mandates, which I noted earlier, but there's often different guidance from the federal, state, and local level. A lot of times there's differences in what the state health department is saying and then how the local health departments might interpret it and the guidance that they give. So that's been a huge challenge. And then another challenge is just that this is a field that already was facing reimbursement challenges, workforce shortages, and so all of those things still remain, and they're really just exacerbated by these increased challenges. So I'm going to walk you all through some of the specific challenges that we see with testing. So testing remains one of the best tools we have to track the spread of COVID-19. And we've been advocating for additional testing and for consistent ongoing testing since the beginning of the pandemic. However, it's very expensive, it's very time consuming, and much of this cost has been passed on to nursing homes, assisted livings, and other providers. So let's walk through a timeline of how Maryland has handled testing in nursing homes since the beginning of COVID. So early on in the pandemic, as you will remember, testing was not widely available. So as soon as it started to become available, we were looking at PCR testing, which is the gold standard, and it's where you send a test off, you send a sample off to a lab, and it takes a number of days to come back. So April 29th is the first time that Maryland mandated testing, and they mandated that all nursing home residents and staff be tested, and the state coordinated and covered this first round of testing. Then in June, Maryland began mandating weekly testing, and the state paid for several rounds of this testing between June and August. So August 15th, the state made the decision that they would stop paying for mandatory weekly staff testing, but the mandate remained. So nursing homes had to contract with the lab on their own and pay between $75 and $125 per test. So that's per individual per week to comply with this mandate. And just as an example, one of our members that I spoke to last week was waiting to get their bill from the lab they've been working with since August, and she expected it to be close to $300,000. And this is a medium-sized provider, not even one of the large providers. So the cost is just incredible for this type of testing. October 1st, the state relaxed their testing requirements to fall in line with the CMS federal guidance. So they were able to test less frequently if they chose to, based on their county positivity rates. Unfortunately, then we started seeing this surge again. So not long after that, the state began mandating on November 17th that staff be tested twice per week and residents be tested once per week. One of the challenges with this is that insurance, private insurance, and Medicare and Medicaid do not cover surveillance testing. And that's what this testing is. So if you've been exposed to COVID and you go to your doctor and you have a known exposure, your insurance will cover that because it's screening and diagnostic to see if you've been exposed or if you've contracted the virus. But this type of testing where you're just tested routinely is not covered by insurance. And so this cost goes to providers, and they are responsible for covering it. So that's kind of a snapshot of where we are with testing in Maryland. So some of the current challenges right now related to testing is really that there's just a lack of adequate levels of resources to enable this testing. It's just not been addressed in a consistent way from the federal or the state government. And we're all learning as we go along, but there are huge gaps in what providers have to provide and what they're mandated to provide and what resources they're being given. And then, like I mentioned earlier, there's these challenges with federal, state, and local discrepancies in what's being mandated. And then PCR testing, which I noted is extremely expensive, costs right now around $65 per test, so it's come down a bit. But we estimate that to meet this new mandate of testing all staff twice and residents once, it'll cost nursing homes about $20,000 per week, just for the testing itself. So that does not include the staff time it takes to coordinate the testing, to collect the specimens, to prepare them to be sent back to the lab, reporting that has to be done. So one of our members I spoke with last week said that They estimate between their two nursing homes in Maryland, they will pay $330,000 per week to fully comply with these new mandates. And again, that's $330,000 that is not being reimbursed in any way. So it's just an incredibly expensive mandate. And then, like I noted, insurance does not cover this type of testing. So that is a huge challenge. And then the state is providing point of care testing supplies, which point of care are these antigen tests. They're the rapid tests. And that is helpful that the state is providing the point of care supplies. However, it's incredibly expensive and more time consuming than to coordinate and schedule and process these tests. So we estimate that every nursing home will need to designate or hire 1 to 2.5 full-time employees just to comply with that mandate to start using the point of care testing. So those are some of the challenges with testing. It's not as simple as having the testing available. It's incredibly complicated. So there's so much more that needs to be done to support providers in this. Some of the things that aging services providers will need to stay afloat, I'm going to detail in a minute, but it's important to think about the incredibly integral role that these settings play in our healthcare system. And we can't afford to not have them be viable. We just can't. We have older Marylanders who need these services, and we need these providers who can provide that service. So what do providers need? They need ongoing access to accurate rapid results testing. So that includes both the antigen and the Pcr tests, and they need it delivered as part of a testing strategy that's comprehensive, and they need the resources to pay for the tests and the increased administrative burden. They need ongoing access to large quantities of PPE to stop COVID from spreading. Like I mentioned, there continue to be huge shortages of different types of PPE. Right now, the items that we're seeing shortages in are gowns and gloves. Early on, it was masks. Now we have plenty of masks. We don't have other things. So it's just really important that that these providers are prioritized and given these supplies. And then ongoing access to financial relief. So you may have heard about some of the funds that the government did give to nursing homes. It's been really patchwork and kind of all over the place with what folks were able to get. There was some money through the CARES Act, through the Paycheck Protection Program, and other opportunities, but those dollars have been spent and spent well. The pandemic is continuing on. It hasn't stopped, and providers need ongoing relief. Another thing to think about is just that we need to prioritize these care settings as highly as we do other care settings. So the amount that hospitals received at the beginning of this was $90 billion. And the amount that nursing homes received was $10 billion. So $10 billion is a huge amount of money, but when you look at compared to how other sectors of the healthcare field were prioritized, it's not equitable. And we know the greatest need is in nursing homes right now. And so it's just really important for us to think about that. And then I'll just say, each of you play a huge role in this. Like I noted earlier, increased cases in larger community is the #1 indicator for increased nursing home cases. And it may not seem like a big deal to get together with a few friends, and it may not be a big deal for you, but it is contributing to the spread in the community, which is contributing to older adults getting sick and potentially dying. So just really important to keep that in mind. So that is all that I prepared in my slides today. I'm happy to take questions. I know we still have a bit of time left. So Eric, I'll hand things back over to you.
Great. Well, thank you very much. And it's pretty remarkable thinking that you stepped into this role in April, right as the pandemic was surging. So I can just imagine, based on everything you presented, how challenging it is. Thinking about some of your member organizations, and this idea that, the new mandates are costing them close to $330,000 per week. I wonder a little bit, I guess, a two-part question here. So I'll kind of lead us off in the questions, and then we'll open it up to others, of course. But, from your vantage point, and obviously you outlined some of the ways and kind of what we can do, both from a governmental perspective as well as individual perspectives. What do you think at this point would be most helpful from your members' vantage point in terms of what could be done, whether it's at the different levels of government or more generally? And also, so kind of a two-part question here. The second part is, are some of them better or less well positioned to weather this? I noticed, some of the disparities that existed, for particularly minority communities. Is this going to have sort of a more profound adverse effect on some of your member organizations? So thank you.
Yeah, those are great questions. So taking the first question, I think what providers, if you ask them what they need right now, it's probably two top things. The first would be money. And I know everyone's budgets are tight right now. State budgets are incredibly tight. We're worried about the state trying to claw back some of the Medicaid reimbursement that they approved earlier this year. But like I mentioned, these providers are a vital piece of our healthcare system, and we have to find a way to support them. So I think financial resources, and I think the other thing is just consistency and getting rid of duplicative processes wherever we can. So for example, when a provider completes a rapid test on a resident or a staff member, they have to report those results in 2 to 3 different places. So they have to report the exact same information many different places. We are lucky here in Maryland because we have CRISP, which is our health information exchange. They are light years ahead of where other states are. And so they've figured out a way to integrate the state reporting with the federal reporting in a lot of cases. But there's a lot of instances where providers have to report the same information at the state, local, and federal level. And so whatever we can do to cut back on administrative burden that is facing these providers, it's to their benefit. So those are probably the top two. And then your second question around disparities and who's maybe better positioned to weather this well. Obviously, providers that went into this with more financial resources are going to be better off. So individual providers that have, like life plan communities, that have different levels of care on one campus, they're kind of diversified. They're not only making money off of their nursing home setting. They're making money off of assisted living, off of folks moving into independent living apartments. And that clientele tends to be a bit wealthier than someone who maybe is on Medicaid and living in a nursing home. So certainly folks that have kind of different levels of care on one campus, and then organizations that are part of a larger organization or chain, they have just greater support and bandwidth to weather this. So, the organizations that we're most worried about losing are those that are standalones. They're not part of a larger organization. Those that have a really high rate of individuals on Medicaid or Medicare, who are lower income. And so, yeah, there's huge challenges, and there's the potential that we could lose providers that are providing the most care to individuals who are in those minority groups.
Great. Well, thank you. And certainly sorry to hear that. I certainly think about what happens then, to those residents when they're part of these communities and in the absence of those facilities that play an important role. So thank you for sharing. I want to give an opportunity to others to ask questions of Ms. Ciborowski.
Thanks, Eric, again, for another great question. Thank you, Allison. It's really fascinating. Congratulations on your new job. I'm a little bit of a ringer here. I'm an adult development and aging psychologist. I'm probably the only chronologically elderly person on this call. But I wanted to just kind of set this in a larger context. I do agree that loss of service is a tremendous issue because the population of older people is growing very rapidly. Life expectancy is increasing. So the need for service is only going to get greater as time goes by, irrespective of COVID. But it is also the case that this discussion is really in the context of one of the most powerful lobbies nationally. It also is the case that individual nursing homes and the largest consortium of them have hired numerous Trump friends and donors to represent them. Mitch McConnell has a Senate bill to protect nursing homes from lawsuit for wrongful death and malpractice. So I'm a little, and I'm raising that because I'd like you to address that larger context. I mean, when I listen to your presentation, I do feel concerned for these owners who have these tremendous unfunded expenses, and certainly those concerns, many of them are legitimate. However, they're not operating in a vacuum, either historically or at present. So where does your organization fit into that? I'm a little also want to ask you, your members are profit and nonprofit organizations. Is that right? Or did I miss that part?
No, all of our members, all of our members are not-for-profits.
What are the business members then?
So our business members are individuals that pay to be part of us, and they can come to our events at a lower rate.
Uh-huh.
They sell services or consulting that our members would potentially buy, like dining, accountants, kinds of things.
There are for-profit members.
They're for-profits. They're not represented in any way on our in our policy work, in our advocacy work. They're not on our board. They're not part of our committees.
So you try to keep those people at arm's length.
We certainly, yes, absolutely. And so I'll just say that because you raise an interesting point about the for-profit and not-for-profit. There are bad actors in every sector of our society. There's nursing homes that could be run better. There are individuals that perhaps are not operating as they should, and that is a reality. I would say the vast majority of those in our field are trying to do the best they can with what they have. So our members are nonprofits in the state. The vast majority of nursing homes in Maryland are for-profit. So we only have about 35, 40 members that have skilled nursing. There's 227 nursing homes in Maryland. So most of those other nursing homes are for-profit. They're not part of our association. They're part of the American Healthcare Association affiliate, which is HFAM. And there's sometimes overlap in our advocacy work and sometimes not. I have a call every week with their president, Joe. Mm-hmm. But they often have a different focus and different priorities than we do, just based on who we represent. Federally, all of the leading age members are not-for-profit. So at a federal level, we're really focused on issues that are of most interest to not-for-profit. So I certainly can't speak for all nursing homes in Maryland or all nursing homes in the country. But that's what I would say. There are instances where there are bad actors, but like I said, the vast majority of providers in Maryland and across the country are working to do what they can to care for these older adults. And as far as the liability issue that you raised with protecting providers, there's huge challenges right now with individual nursing homes when they need to renew their liability insurance. Almost across the board, all companies are adding, all insurance underwriters are adding COVID exclusions. Any communicable disease is now excluded. So if an individual were to bring a suit against a nursing home, it may be that the full case, they would not be found guilty, but that nurse would have to pay for all of their legal fees out of pocket. So whereas before they would be able to get that covered by their liability insurance, they won't any longer. So I think there's challenges, and it's a balance. I mean, we need to protect the rights of older adults and consumers when there are cases of there being a bad actor, but we also need to protect nursing homes and not assume that all of them are acting in bad faith. So I guess that would be my response. And I certainly can't answer. I can't maybe address that as fully as you would like, but happy to speak with you more offline if you'd like to have a conversation. I think you're muted, Lori.
Yes, and I didn't mean to imply that all persons in all institutions are all bad, and that would be a kind of a straw man argument on your side to challenge that. So, but I think it was very helpful to have you said it in that broader context. I appreciate your follow-up on that.
Of course.
Thank you.
Great, and thank you. I had to mute because we're getting some feedback loop when multiple people's speakers are on. So let me see if there's any other questions.
Hi, thanks for joining us, Ms. Ciborowski. I'm Quinn Murphy. I have sort of a three-part question, and I'd appreciate if you, I think you sort of answered part of it with the last question, and that's, so it sounds like all of the facilities you represent, all or virtually all, receive Medicaid or Medicare funds and are bound by these rules.
So we have, that's a good question. So we have one member that does not work with CMS that has a nursing home setting. The rest work with Medicare and Medicaid. So that one provider is completely private pay. They fall under all of the state regulations and mandates. Does that make sense?
Absolutely. So, and I understand it might be difficult to address this question when it comes to both the state and the federal, but you know, address it as you think is effective. So in the slides, you pointed out that all the facilities are required by federal and state law to conduct testing if they're going to take public funds, but they're doing so at this point pretty much out of their own pocket and are not being compensated. So absent that federal or state, you know, absent a stimulus to provide those funds, do you think these facilities would choose to simply not test or test substantially less? And then the coda to that question is this testing effective? Have they demonstrated that staff members getting tested is actually preventing the spread of COVID-19 in these facilities? And if they haven't, I mean, even if it hasn't been demonstrated, is there a sense that it's effective?
Yeah, those are really good questions. So let me, I'm so sorry, excuse me.
Yeah, really good question there, Quinlan. So thank you for asking it. And yeah, and I see Joshua asked about the vaccines too. So thanks for joining.
So sorry, everyone. Quinlan, let me make sure I understand your question. So you're asking if governments weren't mandating this testing, would providers still do it? Yes, I think there's I'll say that every state has handled testing differently. When it comes to testing in nursing homes, CMS has laid out clear guidance based on what they think is kind of the best practice and what, you know, how they've interpreted data. I think and it's changed since March because as we learn more and we have different testing technologies, we test differently. Providers would. I'll say that when the state relaxed the restrictions and said that providers could just test once a month if their positivity rate in the county was under 5%, many of our members just kept testing weekly because they didn't feel comfortable cutting back. They felt like it was important to track cases, and so they just kept paying for it weekly, even though it wasn't mandated for that period of time. So yes, providers would still test. And then can you remind me what your second question was?
And simply, have they found that it's actually an effective tool to prevent spread inside of facilities?
Yeah, it is. It's so I think I mentioned this earlier on that the way that nursing homes are set up now, they cohort residents that are COVID positive or potentially exposed into different areas so that we don't have someone living next door or in the same room with someone that is COVID positive if the other person is not. So it helps us to be able to track that. And we know that the number one way that COVID is entering nursing homes is through staff. So it's a way to be able to keep tabs on if someone is positive and just not showing symptoms yet, having them leave in quarantine so that they're not potentially spreading it to residents unknowingly. Does that answer your question?
I guess there's specific cases of that being successful method of prevention.
Yeah, and like I said, I don't have the data and information in front of me, but I mean, CDC and CMS are continually revising and updating what they recommend for testing based on all of the testing that's now being done and the reporting and being able to track where there are cases and where there are not. So there's certainly more information out there on it, but that I could share with you if you'd like to email me.
Great. Well, thank you very much. Yeah, it's always, hard to think about sort of counterfactual case, right? Like what happens in the absence of having those testing standards. So the fact that different states have different regulations, certainly that's something that, can be explored to see kind of what the impact is. We did get another question. Joshua asked whether your organization has been talked to or been involved about the distribution of the different vaccines for seniors. Obviously, there's been some kind of a beacon of hope, some positive news come out from Moderna and AstraZeneca and Pfizer about these different vaccines. So have you been kind of engaged in those discussions? And I imagine some of your residents would probably get priority.
Yeah, that's a great question. So yes, it is hopeful to think that there's potentially a real solution that is within sight at this point. The way that the vaccine distribution will work, we think, in nursing homes is largely through a partnership that the federal government set up with Walgreens and CVS that you may have heard about. So about 3 weeks ago, nursing homes and assisted livings and affordable senior housing, any setting that had older adults living in a congregate setting, was encouraged to enroll in this opportunity. So how the government says it will work is that the vaccine will be provided to Walgreens and CVS, and Walgreens and CVS will partner with the settings that are in their community to go out and do kind of these vaccine clinics, similar to what we would see with the flu shot clinic. So we encouraged, it was not mandatory, we encouraged, and many, if not all of our members enrolled in that. And so again, we don't have an approved vaccine in hand, so there's no real way to know exactly how it will work. Also, CVS and Walgreens have never done something like this before. The vaccines require specific storage considerations. They have to be kept at very low temperatures, and that's not anything that CVS or Walgreens has handled that way before on such a mass scale. So there is this initiative in place that we hope will work for residents. That is not designed to meet the needs of vaccinating healthcare workers. We think that they might add that in, but they haven't specifically yet. And then the states will also be given vaccine to use as part of their own vaccine distribution plans. So in Maryland, we've advocated, so healthcare workers and nursing home and assisted living residents are already part of the top priority in Maryland. We've been advocating that the state include those living in affordable senior housing and the staff that work in those settings as well. And their response was that they just don't have enough information about how much of the vaccine they'll have yet, and that those who are have the highest clinical need will be given the vaccine first. So that's not really a straight answer, but an answer that we might expect from the Department of Health. So there's a lot of different factors at play. I think until we have an approved vaccine, there's just going to be questions because we won't know exactly how it's going to be transported and delivered. And that's kind of what we know so far.
Yeah, thank you. I mean, I can just certainly, having read about some of the logistical concerns and storage and keeping it cold, and let alone, kind of having that capacity to administer, there is a question, at least among the general population, about some reticence, right, to actually take the vaccine, even if one is available. Do you have a sense from your member organizations if that same reticence exists among those communities?
Yeah, 100% it does. We've gotten a lot of questions from members asking if the state will mandate the vaccine for healthcare workers. And I've had some members tell me if the state mandates the vaccine, I will lose staff. People will quit because they don't feel comfortable receiving such a new vaccine. They feel like they're guinea pigs. And so I would say that's the minority. I think most folks are more comfortable with getting the vaccine, but there are instances where folks are just concerned. And I think part of that is it's the issue of the vaccine has been so political over the last 6 months that, depending on folks' kind of views, they may or may not kind of trust the process. So I think it'll be really important, and we're working on this already with our partners at Leading Age National. How can we really get the information that people want to help them feel comfortable with potentially getting the vaccine? I've had conversations with some of our affordable housing staff members who say they're not comfortable with getting the vaccine, and just really asking them why and what would change their mind, or what would they need in order to feel comfortable. And there's just a variety of factors. So the state has said over and over again that the vaccine will not be mandatory for healthcare workers or older adults, and it will be strongly encouraged, and facilities will handle it likely the way that they handle the flu shot, where if you don't get the flu shot, you have to always wear certain PPE whenever you're at work. They just assume that you have the virus, and you have to act in that way. But like I said, a lot remains to be seen. And I think once we actually have a vaccine and more information, we'll know more about how comfortable individuals are with getting it.
Great. Thank you very much. So I know you have a 1 p.m. hard stop. We probably have time for one more question, maybe two, if it's pretty brief. Anyone have a question? Wait, Lori, I don't know if you were saying something. I think you were muted.
I was, yeah. Thank you. Just a follow up on Quentin's question, because a second question, which I think is really important, and we don't have an answer here, but from a research standpoint, I think it's critical, and that is, what is the actual as opposed to the supposed efficacy of the current ways of handling COVID issues in nursing homes. I'd love to see data on that, Alison, if you have any. But because we do a lot of things without actually knowing if they're efficacious or not, unfortunately. But my question revolves around two things. One is, are you experiencing with your members a level of frustration with the continuously changing protocols and mandates and so on and so forth that you described? If I were in their shoes, I would be very frustrated. And second, not every country is taking the same approach the U.S. appears to be. For example, Israel is planning not to vaccinate the elderly population. Their plan is to vaccinate the super spreader population, which would be young people who have trouble conforming to the rules, and who, because they have lifestyle and life cycle issues, for example, being very social, dating, and then things that are a natural part of that phase of life. that they are putting the population at risk, and therefore they need to get the vaccine so that they can live their lives without hurting others. So it's a very different approach. I'm not sure. I kind of doubt the U.S. will be that. We have a very ambivalent attitude toward the aged population. We underserve them and we overpay them. So if children got Medicare, we'd have a healthier population overall, but we've kind of gone down this path of protecting the elderly.
I don't want to cut you off, but we have like 2 minutes.
Okay. So are you finding that frustration with your members kind of being tossed from pillar to post?
Yeah, certainly. And I think, our members, they want to be operating off of the most recent clinical and best practice and understanding of the virus. So they understand the need for things to change. I think what's most frustrating is when the governor announces something and then the order from the Department of Health doesn't match with what the governor said. And then there's confusion in the actual order itself. So it's not even that the guidance is changing. Often it's that the guidance is so unclear that it's just confusing. So that I think is the even bigger frustration. And I think, there is real ageism in our society in a lot of places, in a lot of ways. And I think we've got a long way to go. But that's interesting about the Israel, their kind of plan for vaccination. And I think it makes a lot of sense. It doesn't sound like that's the way the US will go, but a lot remains to be seen.
Great. Well, I want to thank you very much for taking the time to join us. I know it's an extremely busy time for you, so we're all very appreciative that you're willing to come and be part of the speaker series, certainly representing a very important perspective that, is sometimes neglected. So definitely appreciate you taking the time, and thank you very much.
My pleasure. Thank you all very much. Take care.
Take care.